So on our agenda today, we're going to kind of focus on the IRA and the changes with Medicare. And along with that, the prescription affordability, which is a big issue among beneficiaries in this day and age. And touch a little bit on the rural market because there's a little bit of differentiation between urban markets and rural markets as well. Touch on carrier impacts. What's the business adjustments that carriers are going to have to maybe consider in doing? And what are some of the potential outcomes that could become of it? Alternative options that could be available. Also broker preparation that Tim kind of touched on. Tools that we make available, and then we'll kind of wrap it up with Q&A. So we'll take about 30 to 40 minutes and cover a lot of this information. So the Inflation Reduction Act, it actually was signed back in 2022, and there's 3 or 4 different things that the bill is proposed to do. And one is to curb inflation, another is to lower prescription drug costs, also invest in domestic energy and production of clean energy solutions, as well as Medicare negotiation of drug prices with pharmaceutical companies. Based on this Inflation Reduction Act and when it was proposed and signed into law, you're looking at a savings of about $288 billion to the government when it comes to prescription drug costs. So it's significant with the change that they put in place here with the new law. So, other things that happen with this is that prices within these drugs and with the pharmaceutical companies, they just tend to escalate beyond affordability for a lot of Medicare beneficiaries. So it's important that this is in effect, and it's going to be very impactful to your clients. So regarding Medicare and the reforms that apply to the Inflation Reduction Act, it definitely applies to all the Part D plans that are out there nationwide. It is going to have an effect on the Medicare Part C, Medicare Advantage plans that include prescriptions, so the MAPD plans. It also includes Medicare HMO's plans if they offer prescription drug coverage, so no different than the HMO, also PPO. It does not apply to any supplemental insurance, any Medigap plans, or original Medicare's Part A or Part B. So who's our Medicare beneficiaries? What does that look like? Right now, here's just some very interesting statistics. Nationwide, 11,200 Americans a day are turning 65 in 2024, and it's up from 10,000 from this last decade. So there's significant business that's available out there to continue to build and grow your Medicare business. Even for somebody new into the business, there's a huge opportunity for them to build a solid book of business based on their efforts. 80%, 8 out of 10 older adults live with at least one chronic condition. So if you think about a family member, friends that are in the seniors category, they definitely have one chronic condition, if not more. And on top of that, 50%, more than half of all the people with Medicare insurance have an annual income that is below $30,000. So oftentimes, I'm sure you heard this from your clients, they are working really in order to cover the prescription costs in some cases, aside from just their regular household needs. So it's definitely going to be an impact across the board. And then 6 out of 10 older adults live with at least 2 chronic conditions. So why are these drugs so important? Well, it's definitely helping people live longer and try to live a little healthier lifestyle. So overall, 3.5 million adults 65 and older and 1.8 million Medicare beneficiaries younger than 65 reported affordability problems with prescriptions in 2019. So that number, I'm sure, is going to be escalating as they do data because they always do a look back. But it's definitely a huge issue out here in the Medicare market, whether you're over 65 or under 65. So here we have a nice illustration regarding the timeline for the prescription drug provisions within the Inflation Reduction Act. So if we just look from left to right, in 2022, Medicare will pay what's called the ASP at 8+% for certain biosimilars. And in 2023, they required the drug companies to pay rebates if Medicare drug prices rises faster than inflation. And also it eliminated the cost sharing for vaccines covered under Part D and caps insulin costs to $35 a month. So long as the insulin is on the plan's formulary, then it is capped at $35 for the member. They shouldn't be paying anything more than that. But if it's obviously not on the formulary, they could pay or experience higher out-of-pocket costs or not be covered at all. And in 2024, we eliminated the beneficiary cost sharing for Part D on the catastrophic coverage phase. And then also expanded income eligibility to 150% of the federal poverty level for full low-income subsidies. So, those that are dual eligible Medicare and Medicaid, this is going to actually expand or has expanded in this year for them. In 2025, here's where we're going to see the change come in, where it's going to be a $2,000 out-of-pocket cap in the Part D program, and there's going to be shift risk between plans and taxpayers. Tim, if you can go ahead and change the slide, please.
Yeah, just one more comment on there. So when Jamie's talking about shift risk between plans and taxpayers, and this is one of the reasons why they call it, I guess they call it the Inflation Reduction Act, as well, is if you're familiar with how Medicare is funded, or Medicare Part D is funded, it's actually funded out of the Part B trust fund. And so it's a way to, when they're shifting the cost or the risk from CMS over to the carrier, this is a way that they can help preserve that Medicare Part B trust fund, so it allows it to sustain for years and years to come, from that standpoint. So that's one of the reasons why they're talking about shifting between plans and taxpayers. And you'll see some of the ramifications of these changes because of this $2,000 cap.
So as I just mentioned about the 2000 and the shift risk, this also is going to allow beneficiaries to have what's called a smoothing process, in which case cost sharing can be spread out over the course of a year's time. And we're going to talk a little bit more about that in an upcoming slide. But basically in 2025, these are the main three things that are going to occur. And then there's also going to be some changes coming up in the timeline, as you see. So for 2026 throughout 2029. So in 2026, this is where the drug negotiation is going to be implemented, and it's going to work with at least 10 different drugs that CMS has identified. And these drugs are going to be capped all the way up until 2029, and there's going to be 60 drugs total by the time 2029 approaches. So this is going to be ongoing year after year. But with the price negotiation, it's a way for the government to make sure that there is definitely competition. Also, limit the amount that prescription drug companies can charge, or pharmaceutical companies can charge on their drugs. So they're really trying to identify particular medications, and usually high cost medications, probably $600 or more per month, in order to have it streamlined as best as possible. So here's a list of the first 10 drugs that have been identified for 2026. And then these drugs, deal with a lot of different treatments. So cancer, diabetes, blood clots, heart failure, psoriasis, and rheumatoid arthritis. And here you see the list. And, we all come across these drugs at one point or another, and we're trying to help the members at least with their costs as effectively as possible. And there's, discount programs that are available for beneficiaries that you could recommend in order to offset their out-of-pocket costs. But Eliquis is one that always seems to come up. Januvia is another one that's very popular out there, along with Jardiance. So Xarelto. So these are names that I'm sure you're very familiar with, but they're going to be included in the first 10 drugs that's going to be price negotiated in 2026. But the total, spending, and when you look at this, sorry, Tim, it's over $50 million. I mean, it's tremendously huge when it comes to the impact once they start negotiating these costs. So when it comes to the rural market, just to touch on that, because it is a little bit different. There's different, with the demographics, there's different needs and requirements for folks that live in a rural market. With these 10 drugs, based on data that's been provided, Novolog and Fias, 20% of people in the rural markets, they take that drug, which is tremendously high. So this is going to help for those folks that are in the rural markets. And of the 10 drugs covered under Part D selected for participation, Medicare drug price negotiation program for the initial price applicability for 2026, the share of the enrollees using these drugs that reside in rural areas is highest for those drugs. So it's definitely going to help those folks that do live in rural markets, rural counties throughout the state. So, if they're in Carroll County, for example, I'm just trying to think of some of the other rural counties, Wayne County, Noble County, just to throw out a few different counties out there. So this can definitely help folks living in the rural markets. Again, with the price negotiation that's going to kick in 2025, as you see here in 2026, in 2027, there's going to be up to 15 Medicare drugs that are going to be identified that's going to be part of the price negotiation. And then in 2028, there's going to be an additional 15 drugs that's going to be available for negotiation. And then lastly, in 2029, it's going to be 20 additional drugs that's going to be up for negotiation. So it's going to increase a little over the upcoming years and kind of cap out at 2029 unless there's other changes that come up that we're just not aware of, because that's 4 years, 5 years away almost. And so we'll see what happens. So how does this impact the carriers? What's the adjustments that the carriers need to make? Pretty significant. Right now they're going to be looking at their plan designs. It's still too early to know what exactly they're going to do with their plan designs for 2025, but they have been submitted as of June 3rd, and they're currently being reviewed by CMS. Although that has taken place, we do expect significant changes with these plans, and we anticipate that the adjustment to plan costs, that the cost for the prescription plan may escalate in 2025 with higher premiums, higher copays, or even higher cost sharing to the Medicare beneficiary. And then, the value, the formulary of the formulary modification, so the formula is going to change as well. So when you think about high cost prescriptions that are part of the formulary, those are going to be targeted first, is what we expect to see happen. And so if you have 4 different drugs in one particular category, if 2 of those drugs are a name brand, more than likely they might be looking at either eliminating those name brand altogether or splitting it maybe. That's a possibility in order to still offer a type of name brand. We just don't know exactly what type of methodology the carriers are going to use when it comes to this. So, but that's where Medicare Advantage might still be a good proposition for some of your folks, because when it comes to standalone prescription drug plans, this can definitely make a big impact for folks.
And we'll go through an actual example to kind of show you what carriers can do in terms of what changes that you may see to a plan to help offset, the cost of the prescriptions, especially on the Medicare Advantage side of things.
So another part of the change that's going to take place, I kind of touched on this, is that there's going to be a smoothing process, and we have an illustration regarding smoothing, what that looks like. Retention is going to be big because it's going to be a challenge for the carriers in order to maintain members. So, when we think about the impact, there's going to be a lot of education that's going to be needed for these members, but that's where you come in as a broker and as the advisor, really educating your member as best as possible, making them aware of what the change is going to be and how it can impact them individually with their prescription costs. Also, it's going to create higher service calls levels to the carriers. I mean, right now we know that for the most part, there's no perfect insurance company out there as we speak today. People are calling 1-800-HELL, and then they can't get their questions answered, or they're getting 3 different answers when they're calling their insurance company member service department. So this is definitely going to increase their call level when it comes to service related questions. And then also we just anticipate that the prescription drug request exceptions is going to increase as well. There's drugs right now that are currently not a part of the formulary. And if that's the case, we expect that, depending on what the plans look like and the formularies look like, if they're eliminating some drugs, that you're going to see an increase in requests for exceptions. And that's where you have to really advise your client to talk with their doctor, fill out whatever form is needed for each particular carrier, and hopefully they can get that drug added in and be made available for them to continue. And then also mail order incentives can be added. There's some mail order incentives today as we speak, but not every carrier has them. And what I mean by that is, if you're looking at doing mail order, some of them still charge the same copay for 90 days, or some of them will give you a discount on that third month. So you're paying 60 days, but getting 90 days. So we might see some change there where maybe everybody's offering a discount in that third month. We don't know, but that's what we're hoping to see happen in order to help offset some of the costs for the member. And there's also, it's going to be different. Carriers right now, not every carrier handles everything in-house. So for the most part, when it comes to handling and doing it internally, there's a few companies that do that. For example, Elevance, Anthem, they own their own PBM, but not every carrier does. So some of this could be farmed out to a TPA, which again can add to higher service levels. So again, we'll just have to see how this is going to play out, and we anticipate that that's definitely going to add more stress to the carriers as far as internal operations go.
When Jamie talks about smoothing, this is something that, I mean, obviously we've not seen before, and just wanted to share with you an example of what that looks like and how that actually would work. It's going to be interesting to see, and you'll see probably a lot of carriers maybe struggle around this, or at least struggle on the because now they're going to be be like a bill collector to try to recover some of this money. But the example that you're looking at, this is just a basic example, is the $2,000 out of pocket. If you have somebody that's taking a prescription drug, and like this example, someone that's taking a chemo drug, and their cost per month is $12,000. That individual has the ability or has the option to opt in to say, I want to smooth this out. Instead of having to pay $12,000 or pay a majority of that cost in the month of January, they can now do what they call smoothing out, and that is to make equal payments back to the insurance carrier to repay that up to that $2,000. So for a $12,000 a month drug in 2025, they would hit their annual out-of-pocket of $2,000. It would just be $2,000 in January. They would divide it out by 12 months. So they would repay this to the insurance company $166.67. So the insurance company is still going to pay the pharmacy for the cost of the drug, but now they're going to have to collect the money if that individual opts in to smooth that out. And the smoothing only applies during that benefit period. So if you use this exact example, and let's say in July they are diagnosed with cancer, and they need to start taking this prescription, and in July they would need, it would cost them $12,000. They can say, I want to opt in for the smoothing process, and it would just be that they would hit that $2,000 max. It would just be the $2,000 divided by the 6 months. You can only smooth it out for that benefit period, but individuals again would be then paying a lower payment, basically financing this prescription to the insurance carrier. The insurance carrier is going to be responsible for collecting those payments, basically an interest-free loan, for that.
So, I mean, to add to what Tim explained regarding the smoothing, Tim, when it comes to the smoothing process, there is an opt-in option for the member as well as an opt-out option for the member. So education is really critical here, not just from you, but also from the carriers, because if a person were to opt in and be involved in a smoothing process where they're paying that premium at a lower rate, it's predictable cost. If they miss that premium payment, then they can be removed from the smoothing process for the remainder of the year, which is going to increase their costs out of pocket, because now they have to pay fully out of pocket. So this is something that can be really impactful. It's going to be very confusing for the member who's getting involved in the smoothing process to understand that they have to pay this, no different than any other bill. Otherwise, it's going to cost them more money if they were to miss a payment. And again, this is going to pose a challenge to the carriers because they have to finance this, as Tim already explained. And so it's really important that they realize the effects with the smoothing. So with smoothing, there's also some provisions. So, one of them is the opt-in and the opt-out. If the drug were to cost $600 or more, then they can apply or request to have the smoothing for that particular medication. And in some cases, if it's less than $600, or maybe it's like a $100 medication, smoothing might not be a good option for them. They might just be better off just paying out of pocket in that case because it's such a minimal payment when you spread that out over 12 months. But again, speaking regarding the consequences of the smoothing, members who do not make that subsequent smoothing payment cannot be disenrolled or prevented from filling future prescriptions, but they're going to experience the higher out of pocket because now they have to pay the cost for the prescription in full. And when it comes to implementation of the smoothing process, the pharmacy implementation is still being developed. And as I mentioned, member education is really needed by the plans, the agents, and the PPM and pharmacy stockholders. So this is going to really create a lot of confusion and dissension between members and their carriers when it comes to the smoothing process. They really have to understand that. So just want to kind of elaborate on that a little bit more with Tim.
Yeah, great points, Jamie. So just to kind of show you what the carriers are being faced with, if you look at this chart on the left-hand side, when you look at somebody that has from a consumer side, the left column would be the consumer side. In 2024, if they hit their max, with the coverage gap and everything, they would have 3,324 out of their pocket. But going into 2025, that cap, they're basically eliminating the coverage gap, so their max is going to be 2,000. So from a consumer standpoint, this is a good thing. They're going to see a reduction in their cost of about 40% savings there. But if you look on the right-hand side, in this example, let's just say the plan spends $20,000 total cost to the beneficiary. In 2024, the plan would only be experiencing a payment of $5,330. Again, because the consumer would be paying a lot of that, and then CMS would be paying a bigger portion of that piece of it. But with the shift from CMS now to the carriers, with the $2,000 max, that same $20,000 in 2025, they're going to experience, them being the insurance carrier, 124% increase in payment of prescriptions benefits. So going to go from $5,330 for a $20,000 plan spend, now up to $11,928. So when you look at, we'll talk about some of the changes and things like that carriers are going to do to try to offset some of this. But with the smoothing process, they're taking on additional risk. Because you're going to have some that are not going to make their payments and things like that, so they're going to lose dollars there. And then you look at the additional exposure risk that they're going to be on the hook for now. Again, in like this example, an additional 124% increase on that side of things. So, again, unintended consequences. Understand why. It's a great thing to be able to save and lower the prescription costs for consumers, but there will be unintended consequences due to these changes.
So with
When we
that,
look at the next slide, this is just a hypothetical example. So they're looking at a cost of $38 per member per month to help offset this additional, these additional expenses that they're going to be, or additional risks that they're going to be exposed to. So this is just a hypothetical example of what carriers can do, what changes they can make to help offset this $38. Now, these changes are just specifically for Medicare Advantage. I'll talk about prescription drug changes here in just a minute, but you can see, like from that first box, if they added an additional $100 RX deductible to their plan, they would save $8 per member per month. Adding an additional $5 copay for their PCP, it would add another, a savings of $5 per member per month. Adding additional $5 specialists, again, $3 per member per month. If they decrease dental, $6 per member per month. If they reduce over-the-counter benefits, it would save, $25 per member per month. Increase in surgery copay by $100, it would save $4. And then adding additional $400 to their MOOP, that would save an additional $4. That totals the $38 per member per month. Again, I reiterate, this is just an example, but I wanted to show you that what carriers are going to be looking at going into this AEP, what changes, that they could potentially make, and they may make it in some areas greater than others. Some areas they may not change at all. But that's why I say that you're going to see this is going to be the most significant disruption. They're saying over 90% of individuals will receive an ANOC letter this year. So significant activity. When you look at the PDP side of things, so on the MAPD side, there are a lot of different levers that they can change to offset some of these prescription costs. But when you have a standalone prescription drug plan, there's really not a lot of levers to change to help offset that cost. I mean, you can obviously change the formulary, you can change copays, you can increase premiums, but that's, and they can increase some other things like step therapy, some other cost containment features within the plan, but that's pretty much what they can do. So, what we're going to see probably on the PDP side of things are significant increases. We're hearing as high as 2 or 3 times the premium than what you're used to seeing today. You'll see probably more conversions, more individuals looking at moving their, going from a standalone prescription drug plan, moving over to a Medicare Advantage plan. I don't know if you can see this, but WellCare, there's a letter here they sent out earlier this year. They had that next to zero premium on their PDP plans. I think they kind of knew what they were doing. With this letter here, and this went out to all the agents. As a licensed agent, you should have received it, but it's telling you how to convert your beneficiary from a PDP to MAPD plan. So we do anticipate some changes there. Some individuals, obviously they'll stay with the MedSup and the prescription drug plan, but again, something to consider going into this AEP.
Just to add to that, Tim, is, there's a huge impact when it comes to the Medicare beneficiary. And, when you think about some of your clients that you're speaking with, maybe oftentimes you might hear, well, I just didn't go get my prescription because I just can't afford it, right? So the problem that you have there, it's just an impact of the high out-of-pocket costs, is that, many people will walk away from the pharmacy counter, and 1 in 3 people, ironically enough, have abandoned their medications altogether. Just say, screw it, I'm just not going to get it, just in order to have more money in their pocket to pay for, groceries or whatever, or their bills. And then other scenarios that can occur because of this is that, they might just cut their pill in half, so now they're taking half the dosage in order to stretch it out, again, to try to conserve dollars, or they just skip doses altogether. So, when you think about the impact, there's some statistics about the impact, and really when it comes to non-adherence of prescription medications, it's actually costing nearly $300 billion in healthcare costs. So, and there's 125,000 potentially avoidable deaths because of people, if they were taking their medications, then they would not die, unfortunately. So that's a good thing, but if they're not taking medications, then yeah, it's a bad thing. So these are just ways of how this high cost is going to impact the Medicare beneficiaries and some of the actions that they're taking right now, and really, hurting themselves because of the fact that the affordability is such a huge issue for them. So just want to share that as well.
Yeah, great points, Jamie. One other thing I'll add too is, again, some other unintended consequences. You have a lot of seniors that are continuing to work and they're still on their employer group plan. And with this $2,000 cap, you may start to see more individuals where now that group coverage is no longer credible coverage. It does not meet, the equivalency of the Medicare side of things. So another opportunity, if you partner with some group agents that are not doing Medicare, because we anticipate to see a lot of seniors on a group plan, maybe switching over to over to just their own MedSup and PDP or Medicare Advantage plan, from that standpoint. There are a lot of questions out here real quick. I just want to back up for a second around the smoothing process. So to reiterate, the cap is $2,000. It doesn't matter, I think Jamie mentioned like $600. If you're going to spend more than $600 on a prescription, you have the option, you can smooth that over, over payments to the insurance carrier. But once an individual hits $2,000 out of pocket, they don't pay anything else the rest of the year. They've hit that max out of pocket. So the burden's going to be on the carriers, and then the manufacturers will be given discounts as well, from that standpoint.
So with that $2,000, just so you know, the deductible for the Part D, because now we're switching from 4 stages to 3 stages, you're still going to have a deductible stage. You're going to have the initial stage, and then it's going to be a catastrophic stage. So you just have just 3 stages, but it's going to be $590 for next year. That's going to be the new deductible, but that applies to the $2,000 out of pocket. So if somebody were to pay that deductible, they're going to have a difference of $1,410 that they would still be exposed to. And depending on their drug, you're going to pay 25% of that during the initial stage. But again, once they hit that 1410, then they met their 2,000 max, and then they're not going to have to pay for any medication at that point for the remainder of the year. So that's where smoothing can really help stretch their dollars for them. So what are some potential outcomes? Again, this is all subject to change, but this is things that we're hearing and anticipating, that carriers can stop offering PD plans altogether. We've already seen that happen with Mutual of Omaha. They announced it earlier in the year that they're no longer going to offer prescription drug plans in 2025. So, we don't know for sure, but other carriers could follow suit. Or they could reduce and not pay the full fair market value on the commissions. There's an increase in the Part D commissions going into next year based on the CMS final ruling. Instead of $100, you can get up to $200 in 2025 for somebody aging in, and it's still going to be 50% on the renewal. But a carrier could reduce that if they wanted to, because they could pay up to the fair market value. It's totally up to the carrier. And price plans to not be affordable. So PDP plans have fewer alternatives to premium increase than an MAPD, as Tim pointed out. With the MAPD, you do have additional levers where they can offset some of the costs, where with the standalone prescription drug plan, they don't have that option. They're very limited. So we could see an increase in cost because of that. And then $0 MAPD is still achievable, but lower benefits as value moves to the PDP. So also premium increases. Predominantly on MAPD, that already have a premium. You could see some premium increases on MAPD along with the standalone prescription drug plans. Right now, we anticipate that it could be maybe double or triple in some cases on a standalone prescription drug plan as far as a monthly premium goes. So if you got somebody on for example, Aetna has $101, $103, I believe it is, drug plan, but if that goes up by, let's say, $30, $40, I mean, it's taking it up there almost equivalent to the cost of med sub. So they'd have to really consider, is that something that's affordable for them? And that's where you'd have to, kind of do some of the analysis. And if it's affordable, great. But if not, then MAPD might still be a viable option for them if they're willing to make that change. And then some plans, they may reduce the Part B give back, premium give back. It's less likely that they'll be removed altogether. I mean, it's been real popular on the Medicare Advantage side. So we don't know what that's going to look like as well. But we anticipate that that's going to be affected too when it comes to the give back plan options with MAPD. So alternative options, as I kind of touched on a little bit here, you can compare MAPD prescription benefits to standalone. The formularies can be different and cost share can be lower when it comes to the Medicare Advantage prescription drug plan. Again, if the carrier is able to shift costs, and have those different levers available in order to try to make it affordable still on the Medicare Advantage side, they'll be able to try to make that happen. But again, we don't know what it's going to look like. Provide discount drug card to compare. So we have our drug card. It's called Clever RX. It's available for you. If you don't have it, then just definitely reach out to us so we can get you set up for that. But it works no different than Good RX, where you can have a discount towards the cost of prescriptions. The difference with Clever RX is that it is a commissionable product, so you can at least make a little something on it while you're helping your members at the same time. Where with Good RX, if you're just referring a member there to Good RX, obviously you're not making any commission, and you also stand a chance of maybe losing client because Good RX, they tend to capture beneficiary information. So definitely reach out to us about Clever RX. And you can also check if generic is available for certain name brand drugs because we know with some members, they tend to take name brand even though there's generic available just because maybe mentally they're feeling like, well, I want to get the best and that's what I want to continue to take even if it does cost me more. but that's going to shift. So they might have to have that conversation with their primary care doctor. I definitely recommend that they talk with their doctor. Don't make a recommendation on prescriptions without medical advice. So that's something to consider as well. And then we also have what's called prescription bliss, which is another way to obtain prescriptions at a lower cost. And we can provide information regarding prescription bliss. So what does that mean to you as a broker, and how can you prepare for this upcoming AEP? As Tim mentioned, this is going to be a really strange AEP coming up because there's so many unknowns at this point, and I'm sure we'll find out more as we move through the rest of this year. But really start to communicate regarding to your standalone prescription clients, and we recommend you start early. And early meaning July or August. You don't want to wait till September, October to start sending out letters, especially if you have a large book of business that's standalone PDP. You want to start educating them as much as possible of the upcoming changes, and maybe just creating something that just has some bullet points to just give them a high-level overview of what's coming. And you can also consider holding member meetings, and just hold a meeting, and maybe you can identify clients that have the same plan within the same company. So maybe it might be 2 or 3 different member meetings, but this way everybody's hearing the same message at the same time from you. So that's another strategy that you can take. Check for LIS, eligibility for clients, or extra help. Maybe somebody might have a change in their income, and you're not aware of it. So you can definitely look to see if they're qualifying under the extra help program. Review Medicare Advantage plans. Again, we talked about that as a transitional option, simply because it could be more affordable for them by going that route if it doesn't affect them. If they're not traveling all that much, don't have a second home somewhere, then you might want to consider looking at the MAPD, whether it's an HMO or PPO. And stay on top of industry updates and changes. We're doing our best to make sure that we're keeping all of our brokers informed and educated as much as possible. There's still a lot of information that's going to be coming in. Every day we're getting updates, and there's nuances and talk about this Inflation Reduction Act. So as Tim mentioned, we're going to have continue to have these type of trainings going on, in which case some information we're sharing today, we'll probably have updated information the next time around. And then utilize all of our available tools. We do have tools that can save you time and effort when it comes to capturing information from your standalone PDB clients or even prospects that you're going to be working with. We have a number of ways that you can take advantage of that, and really about embracing technology. Not every broker embraces technology, but if you're not, you definitely need to start considering some of that. So when it comes to some of the tools that I touched on, alluded to, Medicare Center is our online platform enrollment tool that we make available to all our brokers. As long as your contracts are with Cornerstone, you'll be able to submit business via Medicare Center. It's a one-stop shop. Instead of going to 3 or 4 different broker portals and having 3 or 4 different usernames and passwords, we just make it really easy within our Medicare Center platform. So if you're not familiar with Medicare Center, we do have trainings going on regarding Medicare Center and how it works. It's a very easy process to get set up. So myself or one of our other sales directors, Michelle Capp, Colleen Baird, or Paul McMillan, any one of us can help you get set up with that. Then we also have Plan Enroll, which is one of our newer features, and that's a functionality that's built within Medicare Center, again, where you can capture information, send out scope of appointments electronically, capture prescription information, and really get a snapshot of a prospect that you can help to get signed up into a plan. And then we also have Retire Flow, which is really brand new. It was spearheaded by us along with Retire Flow. We were the first FMO to announce this and put it out there for brokers. It's a nice tool where you can capture, again, information up front so that you can be best prepared to help your clients and capture prescription drug information, more importantly, since we're speaking about the Inflation Reduction Act. And Tim's going to touch on that a little bit more. But also scheduling, there's an app called Calendly that can help schedule appointments for you, and it can help you kind of manage your calendar and be a little bit more efficient. So these are definitely things to think about, along with all the back to the basics, grassroots marketing, for those that might not have a big book of business. Make sure that you're working your centers of influence, trying to work all your referral sources as best as possible, getting your name out there. We can assist with marketing pieces as best as possible for you. So it's just a matter of having a conversation with us. Oftentimes brokers, don't realize the things that we can do, but we're not going to know unless you ask. We just can't read minds, and I've had that happen before. So we're always here to help in any way possible. So.
So briefly, I'll talk a little bit about Retire Flow. If you're not familiar, we've done a couple webinars on this, and if you go to our website, we actually have a recorded webinar on Retire Flow. But if you're not familiar with it, it is one way we think is a great way to get in front of your clients today and not wait until you get closer to AEP. And basically, what it is a link that you send to your clients. You can put it in a letter, you can send it out an email to them. When they go into the link or click into the link, it just boils everything down to the very basics. And the basics are prescriptions, doctors, hospitals, pharmacies, lifestyle preferences. It's going to gather all that information. In addition, it's going to provide you with a scope of appointment and also a permission to contact. So I mentioned earlier about the group side of things. If you partner with a group broker or if you're doing group business, this is a link you can give to your group HR person. So when they come across somebody that says, hey, our group plan is not compliant, you're going to have to go to Medicare, to get the credible coverage. They can simply give them that link. The individual will go through. It's very, very easy to go through. Like I said, there's 13 questions, and they just ask them basic information, list your doctors, your hospitals, your prescriptions, and they'll complete the scope of appointment. The permission to contact is in there as well. And then once it's completed, then it would come to you as the agent with all the information. And today, once you gather that information, you can put that into Medicare Center, and you have everything you need going into this AEP. If you need somebody to move now, and you have the ability to move now, especially if they're coming from a group plan or have a qualifying event, then you can go ahead, put your information in the Medicare Center, run your quote, and you're done. But it's going to be a huge time saver when you look at all of the clients that you have today. If again, with 90%, 90+% of the individuals out there going to receive their ANOC letter with some type of change to their plan, they're going to want to talk to you. And no better way than to gather the information up front so you can work in the back end, put in the prescriptions. You can already do some plan recommendations. So all you're doing when you're picking up the phone, you're not gathering all that information. You can actually talk to them about a solution and give them what is going to be the best plan option. We've got the lowest price anywhere in the country with Retire Flow. If you have 2 or more carriers with us, your price is only $9.99 a month. I think the regular price is I think it's $50. So you can see a significant savings there. And if you want to demo, if you want to see a live demo, reach out to myself, reach out to one of our sales directors, and we're happy to set up a demo to kind of go through Retire Flow. But the time to start is, as Jamie mentioned earlier, is now. If you're waiting till September till you start to see plan changes and things like that, I think you're going to be too late. You really need to reach out to your clients, let them know that there are changes coming, and I'm here to help you. So, and you can actually send them the link ahead of time, and they can fill that out, and you can already start putting your these leads coming back to you into your queue so you can start getting things ready. It's going to be a significant time saver, and as we all know, when you get during AEP, it's a lot of work, and it's going to be even more work this year. I think on average, Deft Research says between 12 to 15% look to switch their plans every year. And they think that number, based on the surveys they're doing, is going to be, it could be as high as between 40 to 60%. So it could be a lot of switching. Again, it just depends on how the carriers come back with their changes. Some of the changes may not be significant enough, and your client's going to be fine where they're at, but you just don't know. But to gather the information ahead of time, to prepare, is going to be the best way to help make this an AEP that it's going to be a little bit more manageable for you. We do have, and we are putting together some some letters that you can use, templates that you can send out to your clients. And stay tuned for that. But that is something we are working on to help, help with that communication to your clients. But encourage you to start talking about this now to your clients. Just send them a letter. Just let them know, hey, there are changes coming, and I'm here to help you. When you have questions, please reach out to me. We just got a bad feeling the call centers are going to be really active going into this AEP, especially with on the PDP side of things, where it may be a lot easier for them to capture one of your clients to move them from a PDP to a MAPD plan. So the more you're prepared now, the less likely you'll run across that in going into this AEP. Um, when that form is completed, though, at the bottom there it says bonus PDF summary is instantly generated. So that does come to you, and you do have all that information. And again, I did mention the scope of appointment. All you'd have to do is sign the scope of appointment, and you are completely compliant, from that standpoint. And it has been approved by CMS. It is a fully compliant system.
So to kind of wrap things up before we get into some Q&A, we have a lot of questions out here. Overall, the Inflation Reduction Act will affect Medicare prescription drug plan benefits across the nation. I personally just got back from the national convention this past weekend in Chicago with the National Association of Benefit and Insurance Professionals, and in talking to a lot of my peers and colleagues there, other FMOs, the sentiment is the same across the country. This being a national convention, everybody still don't have all the answers. Everybody's still kind of speculating on what could happen. We still don't have anything specific from carriers regarding this in writing, because we definitely don't want to, we want to be factual as best as possible. So everyone is in the same boat when it comes to this nationwide. So beneficiaries will need expert guidance and rely more on brokers to navigate the changes to ensure the right plan is selected to meet critical prescription needs and affordability. So just as Tim mentioned, you want to get out front on this early as far as communicating with your clients. We're really kind of preaching to you to be proactive as opposed to being reactive when it comes to this. And we have the tools like Retire Flow that can help you manage this as best as possible. So, and then also prescription manufacturers will be held accountable to negotiate the lowest possible cost for certain drugs with Medicare over time to continually reduce out-of-pocket costs of beneficiaries. Again, this is one of the big reasons why this has been, the Inflation Reduction Act has been put in place, is in order to streamline costs and kind of control the increases that pharmaceutical companies have been placing on the cost of prescriptions altogether. So as a broker, again, we touched on this numerous times, and you guys know that you're the expert when it comes to this. So education is a valuable resource to the Medicare beneficiaries. So you definitely want to make sure that you're communicating with them and educating them as best as possible. And we're making every effort to keep you apprised of new information as it becomes available. And so stay tuned for additional trainings moving forward. And so we'll provide updates as best as possible for you. So, Cornerstone Senior Marketing, we're just here to assist you with resources, the support, compliance, and training to help continue to build your business and be compliant along the way. So with that, I think, Tim, is there anything else you want to add there?
No, I mean, I'm going to try to go through some of these Q&As that keep popping in here, but I'll try to run through these and answer. Some of them are similar questions. Let me. Okay, some people are asking about the WellCare letter. I'll send you a copy if you want. I'll send you a copy if you didn't receive that from WellCare. It actually came out, I want to say, a couple months ago, 2 or 3 months ago. I had received it, and I'm happy to share that with you. Okay, there were questions around the $2,000. It's not per prescription. It is $2,000 max out of pocket. You can hit that $2,000 with one prescription drug, or you can hit it with multiple prescription drugs. But once you hit the $2,000, then you hit the max for the year. If the beneficiary misses a smoothing payment, do they still owe up to $2,000 for RX? If they miss a smoothing payment, it's going to be between them and the insurance carrier. If the insurance carrier does not receive their money, I'm sure they will end up turning over to a collection agency and go down that route. But again, it was mentioned earlier, we talked about that if you miss a smoothing payment, it doesn't affect your PDP plan. You can still continue to receive prescriptions. They can't cancel the plan, and it would just prohibit them from doing the smoothing for any other future prescriptions. Um, will there be CMS approved documentation about smoothing we can give to clients? There will be information that we can share with you, Lucy, and share with all of you on the smoothing process and how that works. Couple you've asking for the WellCare letter, and we can send that out. Another question, I'm guessing this will affect the under 65 drug cost. Any thoughts on that? So if they're on a Medicare Advantage plan and they're under 65, yes, it will affect them. It's going to affect anyone that is on a standalone prescription drug or a Medicare Advantage plan. If they're on an ACA plan, it's not going to affect it, like it would. It's going to affect the Medicare side of things. 2000 cap is only 2025. Do we know 2026 cap? We do not, but as of right now, I mean, for 2025, the key is it's going to be the $2,000 cap. And as Jamie mentioned, it's the $590 deductible plus the additional $1,410 in copays, percentages that they would pay up to that $2,000. Will the carrier charge interest during the smoothing process? The understanding, what we have heard is no, it's basically, it would be just that amount divided out by the number of months, and that's what their payment would be. So it would be interest free. A question on the commissions, and this is from Lenny. You are correct. So the full market value on the PDP side of things is the $100 for somebody new and $50 for renewal. So the insurance carriers will either, if they pay commissions on PDP, it will either be the $100 if it's new to Medicare or $50 renewal. Otherwise, they can't reduce it. They can't say, I'm only going to pay $20 commission. It's my understanding, at least, it is all or nothing. So they're either going to pay the full market value or they're not going to be able to pay it at all. And I think that will be the max that you'll see on the PDP side is $100 new, $50 renewal. Sounds to me that our government wants everyone on MA plans. It's kind of looks that way just based on how some of the changes and everything. But I won't say any more else on that. I mean, it's, unless you got any other comments you want to say, Jamie, on it.
No, that's, yeah, I mean, we addressed it, so.
The other question, will Retire Flow integrate into Medicare Center automatically? So I'll spend a little bit of time talking about this. So as of right now, it does not integrate with Medicare Center automatically. So when you send out a link, you get the information, you would have to manually put that into Medicare Center. I think there's a question about Plan Enroll. So Plan Enroll under Medicare Center is very similar to Retire Flow. It's as of right now on Plan Enroll, and there are changes going to be happening to Plan Enroll, which will make it a lot better, but there are additional steps you need to take, or the client would need to take with Plan Enroll, like setting up a username and password. You don't have that feature with Retire Flow. It's a little bit less cumbersome, it flows a lot easier with Retire Flow. We are going to see some changes to Plan Enroll, and we'll definitely be talking about this when we get to our roadshow as we get more information. We haven't seen anything yet, but Um, the changes with plan and roll we probably won't see till closer to AEP. And that's kind of why we're talking about retire flow right now because it's available now. And if you want to reach out to your clients, this would be the recommended tool. You can still use plan and roll and happy to show you demo and comparison between the two. Plan and roll there is no charge for, as whereas the retire flow there would be a small charge for that. But stay tuned for some more information, especially on the plan and roll side of things. Will Cornerstone or the carriers have a standard letter about the Inflation Reduction Act that we can send to clients? So, Marty, yeah, we are. We have one, a generic one that I received from a different integrity partner that they've given permission to share. Happy to share that letter with you. I just got that yesterday. But there are some other letters being worked on that we'll be able to share. So again, we want to make this as easy as possible for you. And again, the goal for us is, we're here to serve you. We're here to make this take a lot of burden off your back to help you see as many and retain as many clients as you can and grow as well. So, you always see when there's disruption, there's opportunity. And we think with the tools that we offer, and again, if you utilize our service team and things like that, put some of that service burden or put all of it on our team because that's what we're here for. It gives you the ability to take care of these other opportunities. Again, we talk about group individuals on group plans. They could be it may not be credible coverage, so now they'll have the ability to you have the ability to help move them over to a Medicare plan of their choice from that standpoint. But there are a lot of individuals that agents, quite frankly, are not going to be able to see, and um, through marketing, through other things like that, we can help you with. We can open the door and help you be able to increase your number of appointments, increase sales for this upcoming AEP. Um, Another question regarding retire flow integrating into Medicare Center automatically. We are working, and the hope is that will happen, but there is no guarantee. All I can do is speak of as of now. It does not integrate with Medicare Center, but we are working with integrity, and the goal is to have that integrate. But there are no guarantees that it will. Uh, Will Cornerstone provide marketing materials for brokers to use for presentations to educate clients and PDFs to use when mailing or emailing clients about upcoming changes? Most definitely, we'll be working on some communication that you can use to send out to your clients. Will Retire Flow give the ability to add provider addresses moving forward? We can check with the developer on that. I have no idea on that, but we can take that question and get back to you, Stephanie, on that. Okay, there are a lot of questions between the functionality difference between Retire Flow, Medicare app. Um, we'll set up a separate, there'll be a lot more information on the plan and roll piece of it. But they're going to do similar things. But again, the retire flow is it's very easy for a senior to go through. And when you look at the overall stats, when an individual, like when an agent sends out links, it's a high percentage of individuals that are actually going through and completing the survey and getting it back to the agent. So there'll be some more information coming up on on some additional training there. Um, okay, the letters, Lucy. So again, we're working on the letters. We'll be able to get those out to you here soon. I do have a sample letter that I received again yesterday that I can share with you. But again, you'll probably want to customize a little bit specific to you and your agency, but this will kind of give you an idea. Do you have any thoughts on how many group plans will not be considered credible coverage? Recommendations on leaving on group plan and adding adding A and PDP. We don't at this time. The employers are required. I think it's at the end of September. They're required to notify all individuals that are eligible for Medicare if their plan is compliant or not. And that's probably when we'll know a little bit more about it, if their plan will be compliant or not. But we do anticipate a lot of those plans may not be compliant because when you make the changes to on a group plan, I mean, they're already seeing significant rate increases, and then you make a change like that, that's just going to overall, put the increase even higher. So I won't say all of them, but I mean, some will be compliant, but a lot of them we anticipate will not be compliant. Um, did the WellCare letter go to clients? I don't think I got one, and I have WellCare personally. Lenny, it did not go to clients. It actually went to contracted agents. And we have a list of everyone that's attended, and I can scan this and I can email it out to everyone that is on the call, so you'll be able to see the letter in that. But I just thought it was interesting when they come out with by far the lowest PDP plan this year, and then earlier this year they come out with how telling agents how you can convert someone from a PDP to an MAPD plan. So um, I assume they're really looking to increase their MAPD book going into this next year. But um, will Medicare Center still be available for 2025? Yes, Jeff. Medicare Center is our platform, and it's one that is owned by Integrity and is being built out. They're adding more and more features every year to Medicare Center, so there are no plans for that to ever go away. Um, if they are removed from the smoothing program due to non-payment, are they removed only for that benefit year? Can they opt in again the following year? That's a great question, Janelle. Jamie, I'm not sure if you know that question, but um,
Can you repeat that
I
again?
don't know specifically. Maybe if they stay with the same carrier, their carrier may say you can't do it, but I'm not 100% sure. I'll have to get back to you on that.
I'm sorry, Sam, what question was that? I missed it.
If someone's removed from the smoothing program due to non-payment, they didn't make their payment to the carrier, are they only removed for that specific benefit year, or can they opt in again following, for the following year?
Yeah, I mean, as I understand it, they will be out for that year, for the remainder of the year. Um, but again, we don't have details from each particular carrier, how they're gonna, what the process is gonna be for them. So that can definitely change. We just don't know for sure. But once they miss a payment, then yeah, they're gonna be out for that for 2025. But when we extend to 2026, don't know yet.
Okay, here's a question. If a person is on Medicare and they get diagnosed with cancer, their prescription costs could be extremely high. So let's say they use the example that you had and pay like 170 per month. They would go over $2,000. What do they do if they pass? Who is left to pay prescription bills? Is there someone that has to pay 170 per month until the year is over? So, Mike, I don't think it'd be any different than um, any other person that is taking out or financing any type of purchase or anything like that. I'm assuming it would go back to the estate, that they would track it back to get their money that is owed to them. Um, Anything you want to add to that, Jamie?
No, no, there's nothing else I really need to add to that. I think you got that covered for now.
Um,
everybody that took time out of their morning here to join us to learn a little bit more.
Just getting more questions on well care letter, and again, I'll send that out to everyone that attended the webinar today. Some members have trouble with retire flow, moving from screen to screen. Can we help members navigate retire flow during member meetings to get the filled out correctly? Yes, Tammy, you can, because it is a link that you can bring up and you can ask the questions and fill in the information. And again, that would just come back to you once it's completed. You submit it, it comes to you as the PDF, but you most certainly can fill that in. Will we be able to see the smoothing cost in Medicare app when discussing drug costs with a client? To my knowledge, there is no smoothing piece of it in Medicare Center at all. So, Rick, the answer would be no. It's not going to be in Medicare app or in Medicare Center, to my knowledge. More information on the communication. So we're working. We'll get the communication out to you. The communication letters to your that you can send to your clients. Another question. I thought I saw a slide that stated that carriers are capped at a 6% increase on premiums. Is this correct? You have information on that, Jamie? I know
Yeah,
it's not.
that is
I'm sorry.
written out there. Yeah, that there's a 6% cap on premium, but we don't know what those premiums are going to be for next year. So I mean, we can't give any specific numbers to that. But yeah, I mean, it was written out there, but I just don't know how that's going to be implemented.
Yeah, and it's not that it's the 6% is not the premiums that they charge for their plans. It's the and I'm at a loss of words on it, but it's um, I'm drawing a blank now, but it's not this it's not saying that they can't increase the premiums to individuals by 6%. That is not the case from that standpoint. I'll get you some more information on that, Kelly. Another question here for participant. Say participant fails to pay the amount they are billed by the Part D sponsor, their participation in the program may be terminated following a required 2-month grace period. Importantly, the Part D plan sponsor is not permitted to terminate the individual's enrollment in the Part D plan due to failure to pay Medicare prescription payment plan bills. Part D plan sponsors must also have a reinstatement process in place to allow individuals to resume participation in the Medicare prescription. I think this is just an answer to one of the questions, but it reiterates the fact that if somebody does not make that payment to the insurance company for the smoothing piece of it, they cannot be terminated, from their plan. Is this going to force the PDP vendors to lock in their drug card formulary for the entire calendar year? Any thoughts on that, Jamie?
Repeat that. I'm sorry. I was trying to answer a question as you were saying that.
Is this going to force the PDP vendors to lock in their drug card formulary for the entire calendar year?
Well, typically the formulary is set for the calendar year. I mean, I've not seen formulary changes in the middle of the year because again, all that's submitted to CMS. So I would venture to say yes, that it should just lock in that formulary for the year, no different than the benefits are locked in for the year on an MAPD plan.
All right, it looks like those are the questions that I'm seeing out here. A lot of the duplicate questions out there, but we appreciate everyone's time today. Again, a lot of information, a lot of moving parts that is happening. Here's Jamie's contact information. If you have any questions, feel free to reach out to myself as well. We're here, everyone here at Cornerstone, we're here to help you. We appreciate your business. We appreciate the partnership. And again, we look forward to helping you through this. We're always looking for technology, ways to make it easier for you, because obviously retention is the name of the game, but during AEP, opportunity and growth is also there. So we're here to help. Please reach out to us. We've got 18 employees here, and they're all, I think everyone on the service team is trained, they're certified, so they go through what you go through in terms of the certification process. And when you look at it over all the years, we've got hundreds of years of experience when you total everyone up here within the company. A lot of knowledgeable people. So please reach out to us, and you know, that's why we appreciate the partnership. We want to grow this together. We can't be successful unless you're successful. So appreciate everyone's time. Please reach out to us again with any questions.